My name is Dr. Sarah Zigley. I'm a physical therapist and an orthopedic clinical specialist. I've been in practice for 12 years. I started my career in outpatient orthopedics at a level 1 trauma center and sports medicine hub in the Milwaukee area. I was there for about 8 years. I then transitioned. I was an adjunct faculty at a program in Wisconsin, and then we transitioned to Louisville, Kentucky. I was an adjunct professor at a physical therapy and athletic training program in Louisville, Kentucky as well. And I also founded a private practice at that time and runner's clinic. So I have an orthopedic practice and a runner's clinic. I now practice in Oshkosh, Wisconsin, where I'm also a workplace consultant. So I'm oftentimes in occupational settings. I have an on-site clinic and a manufacturing facility as well. So a little bit of a broad gamut. I also am an advisor to a tech company who specializes in ergonomics. So overall, that's a little bit of my background. Today, we'll be talking about running related injuries. So this one is very near and dear to my heart as a runner's clinic provider. So as we go through, we'll use lots of real life examples along the way. For today's course notes, if you would like to download a copy of them for reference either on your test or to look back at later, this is how you would go about finding them. So we've got cheapceus.com, continuing education courses. After you go through your profession, that's where you'll find today's course. Once you find today's course, then there'll be this little icon here that says click here to open notes. That'll link you to a PDF of today's course notes. So all of the slides will be available for you there. The overview for running related injuries today is that it is a real-time interactive webinar. It's for rehab professionals and examines orthopedic injuries related to running. The course includes the review of current literature. It's related to gait mechanics, clinical presentations, treatment considerations, all for running related injury. The academic rationale for why we're here. This is the part that talks about how we're going to get evidence-based information on running-related injuries. We're going to do comparative analysis on things today like kinematics and clinical presentation. And overall, it's going to help us understand the rehab considerations. It's also going to help us to maximize the outcomes based on our current research. So overall, the rationale for why we're going to do this course, a lot of us treat runners, or at least people who to some degree integrate running into their life. By knowing more about current evidence, we can do a better job taking care of these patients. And I bet for a few of us, it's probably also going to be personal if you're a runner yourself. We have a list of 10 objectives on this slide here. It is in the course notes, but if you need a closer look, you can take it. I will verify that we get through all of these points before we're done today. Just a disclaimer on how to use today's content. So the application of the concepts presented in this webinar are at the discretion of the individual participant in accordance with your federal, state, and professional regulations. We have people joining us from all over, which we love, but it is up to the participant in order to apply it appropriately. There's no conflict of interest for the presenter or the provider of the course. And a little insider tip, if this is new for you with us today, or just a little reminder, this little hexagon is your friend when you are going through the course slides. So if you see that little hexagon, what that tells you is that the information on that slide is going to be particularly relevant for the post-test. So you might want to put a little extra star or pay attention on that slide in a different way, so you make sure you have the content necessary for the post-test. So then why are we going to talk about running? Let's just jump into it. So about 60 million Americans have been documented to run each year. So the population that we are talking about is massive when it comes to runners. This is different than when it comes to other sports, because when we look at the global numbers, it's more than 600 million people worldwide report that they, in some degree, utilize running for exercise. We know that the age of runners is also increasing. So not only are there tons of runners out there, but the age is getting higher. So when, unfortunately, we age as human beings, we tend not to have less injuries. We tend to have slightly more. So as we look at the ages on this slide, we see that the 5K age used to average at 32, and today is closer to 40 years old. So our runners are having slightly more middle age problems than they used to when we were having these averages closer to our early 30s. One of the reasons we see so many people run is the relatively low barrier to entry, right? If we were to all pick up and play ice hockey for the first time, we would need lots of equipment, we need lots of training. There's a lot of barriers that come to that: access to equipment, access to facilities. When it comes to running, if you want to just pick up and run, really you can do so with not much more than a pair of shoes. So a lot of people pick up running because of that really easy entry into the sport. We know that unfortunately, runners also get hurt a lot. I think one of the statistics that's really staggering is that up to 70% of runners sustain an overuse injury every year. So sometimes when we look at data like this, we see, okay, 70% of runners get injured, and that would be in the lifetime. But if we look closer at this data, what it's saying is not over the course of their time as a runner. This is each and every year they're a runner. So 70% chance on an annual basis that a runner is going to be injured. When we look at those numbers of 60 million Americans, plus 70% of them are having overuse injuries in a given year, I think what that kind of ends up pointing to is the fact that a lot of these people are going to be walking into our offices. So we need to be prepared to treat them. Um, we also have to just put a nod to the fact that some of these people are recreational runners. However, not all of them are purely recreational runners, right? We also have occupations that demand running. When we're talking about a lot of our tactical athletes, so our people like soldiers and firefighters and police officers, our correctional officers, just to name a few of the ones that come to mind from my own practice. But it's not just people who are out for a leisurely or a recreational run. Part of the reason that these statistics are so high is because of the high impact forces. So we've got 1.5 to 5 times your body weight hitting the treadmill or the floor or the ground every time that you take a step. So those high impact forces on a very repetitive cycle are part of the reason why we get to this point. And of course, what does that mean when it comes to the impact of the injury itself? Not impact from a kinetic perspective, but impact in talking with kind of what does this mean for us economically? $4 billion are typically spent on running injuries, again, per year. So this is a big recurring expense on the healthcare system. Let's all get on the same page kind of early on here for what really we're talking about when we're referencing some of these common gait related terms. So the first one we'll talk about is step length versus stride length. So the difference between a step and a stride is how many of the footsteps we're talking about. So a step length is from left to right or from right to left, where a stride length is going to include both left, right, left again. So essentially, if someone had a symmetrical gait pattern, a step length would be approximately half of the stride. Now we know that that's not always the case, especially in the case of injury, but those are the general terms that we're describing with step versus stride. The gait cycle is just the interval to complete that full stride. And then when we're talking about cadence or step rate, we're usually talking about the number of steps taken per a unit time. And that unit time is almost always reported in the literature in steps per minute. And that one will be particularly relevant as we're talking about gait retraining strategies because cadence has become one of the most talked about interventions for gait modification. When we're talking about the gait cycle and the different components of it, we start really at initial contact, or in a cycle, there's really no one specific starting point, right? But I'm kind of thinking about that first step, foot hitting the ground. That is the point in the gait cycle when we get foot contact. Now, historically, it was usually referred to as heel strike, although we know we can have multiple different initial contact patterns, but kind of heel strike being the most classic. Mid stance then is the point in the gait cycle when the two limbs pass each other. So that would be considered mid stance for the limb in contact with the ground. Then we've got heel off, which is the point in the gait cycle when that stance leg first elevates the heel above the ground. And toe off is when that stance leg completely loses contact with the support surface. This is that continuum that we were talking about. If we were talking about kind of starting the picture with initial contact, that would be the beginning of our loading phase. So when we're starting to hit the ground, starting to accept load into the weight bearing system. It's transitioning through mid stance. Mid stance is kind of what we think of as a transition point where we switch between loading and propulsion. Then propulsion is where we're really starting to get our body pushed off forward. So those are going to include our phases such as heel off and toe off. And then our swing phase is typically divided here into two different parts. We've got initial swing, which is the part where that leg is really trailing our body and still working its way forward. And then terminal swing or float phase 2, where it's starting to progress towards its point of initial contact. So these will be the phases that we're really talking about, especially as we go through gait analysis. These are just a few screenshots from one of the runners clinics I've had. This is, I think, the one I had 2 years ago. And the phase we're talking about here is that loading phase. So beginning with the initial contact, you can see the shadow below the heel is gone. That's usually one of the primary signs that I watch for. When the foot is coming down towards the treadmill, you'll see the shadow of the shoe, as soon as that shadow is gone, we know that we've made initial contact. Sometimes, depending on people's attire, you can also see the muscle contour start to engage between being in float phase and actually being in weight bearing. So that would be the image that we're looking there for the initiation of loading phase. Then to exemplify mid stance, here you can see it actually looks like she has a single leg with two shins coming out of it. That is our kind of target image slide frame for mid stance, because it appears that those legs are cleanly passing each other, and really begins when we've got that transition point between the two. Here we start to look at the propulsion phase, because you can see she has established a plantar flexion position here and her heel is lifted off the ground. What you can't see from this plane, but that rear foot is actually starting to invert as she does that. So as we go into that heel off, we'll start to get a little bit of that inversion as they are generating power through the lower limb. And then our float phase, you can see here, the toe has actually left the treadmill. There's some space there, and the opposite limb is yet to hit the ground. So that would be considered our float phase 1 or initial swing, followed by our terminal swing or float phase 2. So that foot is now pre initial contact, still floating above the ground. When I am talking with a runner in the clinic, I think this depiction is really helpful in both guiding our evaluation in our treatment program, but also communicating with our patients. So when someone comes in to your office with a running related injury, there's treating the issues at hand, right? Treating the pain that comes into the clinic. But then we also need to be treating the causes, right? So when we see what, we have to be thinking about the why. And this slide is really exemplifying the 3 categories of the why. So we've got anatomical, training, and biomechanical reasons or risk factors for why someone gets hurt. So when we're talking about this to our patients, I usually describe it as 3 buckets. So I talk about it's how you're built, how you move, or how you train. Those are the 3 things that we need to look at to how we got here. So how you're built. So these are going to be things like how flexible you are, how strong you are, what's your static postural alignment. These are how you are made. Then we look about how you move. So just because you have these different underlying characteristics doesn't tell us how you use them. So that biomechanical bucket, that how you move, those are our gait mechanics, those are our loading tendencies. That falls into the second bucket. The how you train is how we use these systems and what kind of demands we put them under. So our how we train bucket is going to be things like, have you taken any relative rest? Do you do any cross training? Have we made recent changes or increased our volume by a high amount? Those are going to be the things that we're talking about in the how you train. So if we leave one bucket unchecked, there's a chance that once we return to activity, it's going to have a recurrence of injury. So we really want to make sure that we clear out all of the buckets. Let's start with the training one. So I think this training one is really what it comes down to overall, right? Because we're all built a certain way, we all move a certain way, and if we stay within the capacity of that system, we don't get injured. If we exceed the capacity of our system, then we have a problem. And really, how we're built and how we move is just going to essentially change how tolerant that curve is before we have an injury. So I think this diagram here is one that's really going to come into play throughout our entire presentation today. On the y-axis, you see how much stress is applied. So this is our load, this is our training demand. And then on the x-axis, you can see frequency. So how often are we applying this load? If we have higher stresses, higher loads, intuitively, we need less frequency. So we can do higher loads not as often and still stay underneath this curve. So that will bring us over here. If we are applying a lower degree of load, then we can tolerate doing it more often. So again, if we kind of think about this even from like a marathon training program, how often can we run 20 miles without getting hurt versus how often can we run 2 miles without getting hurt, right? That threshold is different. So our overall goal is to stay below this line. If we stay under this line, we should be in that glorious category called no injury. As soon as we jump up into this category, being above that threshold, now we are likely to get hurt. So our whole training protocol should be to try and balance the load and frequency to have adequate time for adaptation so that we can stay below that threshold. And again, that's kind of the difficult part, is because unfortunately this threshold is invisible. So we're always kind of chasing it and trying to find where it belongs. If we're talking about overuse and going over that threshold, we need to think about what determines that training load. Is it just mileage? And really the answer is, of course not. It's not just mileage. 5 miles isn't 5 miles no matter how and when it's done. So the first category is that external load. So we've got things like distance, so the 5 miles, but we also have how long did that 5 miles take you? How many steps were in that 5 miles? How much force was produced during those 5 miles? Those are all determinants of external load. But then we even have other categories we need to be thinking about as well. Physiological internal load, that's how hard is your system working to achieve that? So our ratings of perceived exertion, I think anyone who's done any version of physical exertion, whether it's running or not, can tell you that it doesn't feel the same every time. There are some times where you go out for a 3-mile run and it feels relatively easy. There are times where you go out because you didn't sleep well the last 2 days, because you've had a lot of stress, and those same 3 miles feel a whole lot harder. Those perceived exertion ratings matter for your internal load. And then finally, we've got the internal tissue load. So that's the actual stress and strain on the actual tissues and maybe the stiffness in those tendons. That is going to interplay with those other 2 categories to really create that threshold of overuse. These are a few other compounding factors that go into that. So speed is one of them. We know that it's a little different if you're running a mile at a 5:30 pace, if you're running at a 12-minute pace. Surface, so things like, are you running on sidewalks? Are you running on beaches? Shoes can make a difference. Terrain, we all know that running hills is not the same as running flats. We're talking about weather. If you've ever run in a headwind, you know that feels a lot different than running with some wind pushing you in the back. If anyone does an out and back loop, you will definitely know that you want to pay attention to whether you're starting off in the head or the tailwind, because otherwise the run back is going to be a very different animal. We talked a little bit about the fact that sleep and nutrition matter, right? You haven't eaten, you haven't slept. That makes a difference with how hard you work, as well as any prior injury history. All of those compound to create where that threshold is for overuse. Then that puts us into the next bucket we're going to talk about, which is anatomical, how we're built. So they did research to try and identify, are there specific postural characteristics that will tell us how likely someone is to get hurt? Well, they found that there were some that were cleanly aligned with increased risk of injury. Those were having limited dorsiflexion, having pes cavus, a leg length discrepancy, or the high Q angle. Interestingly enough, other research has found that there are some characteristics that have been shown to definitively not increase your risk of injury. And if you come and look at this list, it's limited dorsiflexion, pes cavus, leg length discrepancy, and high Q angle. And that list and the list on the last page have as much in common as the two women sitting at this table. They're essentially identical, right? So how can that possibly be? How can we have some research saying, oh, if you have a high Q angle, you're going to get hurt? And the same list of things saying, well, if you have a high Q angle, nothing is at an increased risk. Part of it explained by the fact that anatomy doesn't survive in a vacuum, right? We need to have the interplay of our anatomy and our biomechanics. So there's how we're built, but there's how we use the system that we have. And that's how these same characteristics can both be an increased risk factor for some and yet not for others. What about strength? So we know posturally, we don't really have a magic answer for what people are going to have as an issue. It has been shown that strength training during a running program has been shown to reduce the risk of overuse injuries. I don't know if you necessarily have to be quite to the extent of these excellent posers on this page. However, the strength does have the role of potentially increasing that tissue condition, increasing the failure threshold, or just giving some variation so that it's not undergoing the same stress of impact exercise all the time. So if we don't have to be bodybuilders, what is it that we should be doing? There have been some research articles that have looked on, can we just strengthen our core? Is that enough to make us have this protective effect of strength? They have found that it's not quite enough to predict our overuse injuries just with core alone. So we probably need a more comprehensive program than that. And if you are having difficulty convincing your runners that they need to be doing strength in addition, which sometimes is harder of a sell than we'd like it to be as BTs, if we can sometimes talk to them about the performance benefits of strength, that can have a little bit of a motivating tendency in our running population. And the metric that's been shown to improve is actually running economy. There's also flexibility when it comes to anatomic characteristics, and this is the one that most runners will come in and already be talking about. I cannot even count how many times an injured runner comes in for their new eval and says to me, I know I haven't been stretching enough. And it always makes me smile a little bit because my first question is, do you even know if you need to be stretching? You seem to be really convinced that that already was the cause of the issue. So despite a lack of research to support it, stretching is actually the most commonly utilized strength and conditioning activity amongst runners. So if a runner is out there and just going to do one other strength and conditioning thing to support their running program, most commonly they're going to choose stretching over plyometric training or strength training or any of these other modalities. flexibility tends to be the way. Although, really, we don't have any research that says being part of this prophylactic flexibility program is really protective in any way. Hamstring tightness, they've done specific ones looking at that and pelvic positioning. We don't really see any direct implication on how it impacts our running form. What about gender? When we're talking men versus women, some studies have really shown that the risk between them is fairly similar. What I think is most interesting is that when they are injured, what happens is slightly more likely to be one versus the other. So women have higher chances of getting bone stress injuries. Men actually have a higher risk of Achilles tendon injury. So we're looking at a little bit more soft tissue when we're talking about male running injury. Biomechanical, so we're kind of moving into that third and final bucket, how we move. That we're going to tease out of this section and actually put in its own because I love talking about gait mechanics. I think it's really important to be able to talk about that. So we're going to dedicate a whole section to it in a few slides. The final thing I really want to bring up when it comes to risk factors for running injury, one that is consistently supported by all of the literature as a risk factor is the prior injury history. So when you have a runner who comes in and is talking about something that's going on currently, it is imperative we talk about what's happened historically because it is very predictive of what we might see in the current situation as well. So, in talking about some of those questions, and when your runner is in front of you in the office with this new injury, this is a list that I've compiled of some of the things that I always want to include in that initial conversation. Mostly because we can see anatomical factors. We can often see biomechanical factors, but we can't see in our office the training factors. So these, a lot of them are trying to get at what their training program is like to try and really fill that third bucket with anything that we need. So one of them is any recent changes in training. Sometimes people have striking increases or decreases in training. Typical running routine look like? It's really helpful for you to learn early on. Are you dealing with someone who's an ultra runner who is putting on, 100 plus miles a week? Or are we talking about someone who's typically in a maybe 3, 4 day a week with alternating rest days in between or lower volume? I like to know about things that they do other than exercise. So things like strength or cross training, yoga. Those not only help to identify maybe any gaps in their training program that we may be able to fill, but occasionally these may also be irritating the symptoms. Specifically, when it comes to this recommendation of yoga, when people have things like hamstring injuries or impingement in the hip, yoga may be one that they think is productive for them, but may actually be counterproductive to their goal. I like to know how long someone's been a runner because that has a lot of information on their body's adaptability over time. Is this an activity that they're really accustomed to, or is it something that their body is really acutely adapting to? Of course, the question we posed on the previous slides, have you ever had running injuries before? If someone tells me that they have like deeper hip pain when they're coming in, and then I talk about their prior injury histories and they tell me they've had a metatarsal and a tibial stress fracture before, number one thing I'm going to put on the list right away, femoral neck stress fracture. That's the thing because we know they have bone density issues. History is kind of our best way of guessing what might be happening currently. Kind of things can batch together. So again, prior injuries is really helpful to kind of create our differential list. And then I always want to talk about what their current training is for. So we're going to have very different strategies for rehabbing a runner who is in training for an upcoming race in 2 weeks versus someone who is maybe in the off season or in their first couple weeks. It helps to determine, are we in a patch and get through this pain management until we get to the finish line? Are we talking about building up a base and really making things right so that they have something to grow off of for the rest of the training cycle? Or are we thinking about kind of a beg and borrow where we're trying to get the best that we can now while still leaving some exertional load tolerance on the table for upcoming races? So that's all the ways that we use that data when we're trying to create our rehab strategies. Then we switch into that objective exam where we can start to look at how they're built and how they move. So how they're built often starts with a postural assessment. The reason we want to talk about postural assessment is because if we see them move, and a great example of this just, I think it was 2 weeks ago when I was in my clinic, I had a runner who during their left stance phase showed a really strong lateral lean towards the same ipsilateral side. I kept seeing this kind of left shift, left shift, left shift. I asked him to come back and we stood on the ground and did a postural assessment. In standing, not running, he was already left shifted. So had I blamed the left side for that shift, we would have probably missed the fact that he had more of a disc issue that needed to be corrected in postural, standing postural shift before we could do it dynamically in running. So really all of these different postural assessments are just giving us a baseline so we can identify whether they're dynamic or whether they're static postural issues. Then I like to look at some of these things we would call like a functional movement screens. The first few on this list come directly from the research on how should you evaluate a runner in your clinic. The last two I put a little asterisk on because these are my personal additions to the research, just the ones I like to do in my clinic. So we'll talk about how they come together. The double and single leg squats, these are great because they're going to show loading in that flexed position. Single leg squats, especially, I think are valuable because they show us how we do that single limb loading, which is very similar to our loading phase of running. Hurdle stepping and lunges are kind of similar in that dynamic loading and movement pattern, and then rotary stability as well. I personally really like hop tests because they show us how someone handles impact, how they handle impact propulsion, but then also how they accept load. So I like to add that in single leg balance because usually if someone can't stand on one foot, I'm not sure how much stability I'd expect them to have when they're running. A few more pictures here of my husband demonstrating these different positions and tests. I can tell you he put on his best effort for these because that single leg squat, when you watch him move when he's not in front of the camera, it's not nearly that clean. A lot more valgus happening when he's not being watched by his PT spouse. These are some non-weight bearing tests, so just looking at things like joint range of motion, strength, because when we know these baseline characteristics, we know whether it's someone's more mechanical, habitual reasons for seeing some of the gait mechanics that will pop out on the running eval versus whether it's actually a deficit in the underlying system. So then to hop into the gait analysis portion of it, this is a picture of my current runner's clinic set up here. You're going to do a qualitative video analysis most of the time. That is something that all you really need is a recording device that now can be a tablet. It can even be a phone. As long as it's 120 frames per second, which I don't even know if they make devices less than that anymore, you should have what you need. And then you'll want some version of measuring joint angles. So you can use a motion capture app. There are a lot of paid versions out there, or you can use something that's more of a screenshot and measure type of app. There's lots of options that you can utilize. And you'll want your patient to be in more form-fitting clothes. It just helps you to see their angles better. Shirt tucked in is going to be the best way to be able to evaluate the pelvic alignment when we get to that point. And they'll always ask, how do you want me to run? And I think the best answer to that is a mid-run pace. I always tell them that I don't want them to try and impress me with their speed. This is not necessarily race pace. I'd rather see training pace. And we want to just have something that feels like they can settle into it. The data has shown that after 6 minutes of running, someone tends to naturalize into their typical gait pattern on a treadmill. So if you give people a little bit of time to really settle in, you'll get overground mechanic crossover to the treadmill. So people will often say, well, I run mostly outside. Is this really going to be able to show? And they have compared research on overground mechanics compared to treadmill mechanics, and the crossover is very similar. So you can really infer a lot about how someone runs outside by how they run on the treadmill. When you're going to capture your video, you're going to want to have all the different planes. So typically, I'm going to do a wall sit here in front of the treadmill, get in some quad burn while I video from the front for an anterior view. Then you're going to want to standardize your position to be perpendicular to the treadmill from the lateral view. And then what we can't see here is you're going to want to do something from the posterior as well. In a perfect scenario, you'd actually be able to record from both sides. Otherwise, you're just going to have to kind of infer the right mechanics from the video on the left. So when we're actually doing a gait analysis, then we can look at certain characteristics across the different joint regions. So from the lateral view, we're just talking about looking at it from the top to bottom in this characteristic I have here. So I was always informed early on when I was training under Dr. Brian Heiderscheit at UW-Madison to pick a system. So either go from top to bottom, go from the bottom to the top, choose a joint region and kind of work out from there, but have a way that you systematically approach how you do gait analysis so that you can reproduce it across times with the same patient or across different runners. So in my practice, I've opted to kind of stick with the top to bottom. So I start with the trunk and then I work my way down. So with the trunk, with that forward lean angle, we're looking for about 5 to 10 degrees. The more forward someone is, the more forward their center of mass comes, which is helpful for initial contact. With arm swing, we're looking for symmetry. And then with the pelvic tilt, we're looking for how much anterior tilt do they have. With the hip, we're looking for their degree of extension. So usually around 5 degrees is what we'd anticipate. In the lateral view with the knee, We're looking at their extension at a few different points. So at initial contact, we would look at extension of the knee and anticipate around 20 degrees is what we would want. Anything less than that, and someone has a more extended knee, then we're going to reduce their impact absorption. At mid stance, this amount of flexion increases, typically to around 40 degrees. We don't want this to get too big because otherwise we're kind of sinking into it and we're losing that recoil. With the foot and ankle, we're looking at the ankle position at initial contact. So this is from the lateral view, really our foot strike pattern. So heel, rear foot, midfoot, or a toe runner, toe strike. And then if we're looking at contact time with the treadmill, we can look at it in this view as well. From the posterior view, now we're going to be looking at these same regions, but a slightly different characteristic. So for the trunk, we're going to be looking at the lateral lean. We would expect that someone would stay relatively centered over their midpoint. We're looking at symmetry of the arm swing right to left, and as well as pelvic drop. So for pelvic drop, we're really looking for women to be between 4 and 7 degrees of pelvic drop, where for men, they'd be closer to 3 to 5. We can look at adduction of the hip, and then coming down to the knee from the posterior view. Now we're going to be looking at any contact they have if they're adducting a lot, or any kind of internal rotation. And then the foot and ankle, this is where we're going to be talking about inversion and eversion of the calcaneus, or what most patients are going to be looking for information on is their pronation and supination. And at this point, I always like to point out to patients that some degree of pronation is actually desired because that's going to absorb our load. So when we're absorbing a little bit of load, then that allows us not to transfer it all up the chain into our tibia, our knee, or our hip. So those are some of the characteristics that we look at from the posterior view. And then the transverse plane. So this one's a little bit more difficult to directly observe because we'd have to have essentially a drone coming down from the top, which maybe is on the horizon for clinics. You never know. But we can infer from the arm swing and from the pelvic rotation and heel height how that transverse plane is going to look. So that can be another angle that we evaluate. Our gait can be influenced by things such as our age. We know that as we get older, we might have modifications like decrease of the float phase. Fatigue also matters. I always like to remind people that when they're in my office, oftentimes I'm seeing the freshest, cleanest mechanics that they offer. If we were to look again at mile 10, or if we were to look at mile 15, we might see all of these things kind of bigger and badder than they were in the office. So if we're seeing norms that are maybe slightly skewed from where we need them to be, I would anticipate that with fatigue, the potential is there that those are going to be even bigger. Just a thought about kinematics versus kinetics. So when we're doing a gait analysis on a treadmill in the office, we're talking kinematics. We're not actually observing forces. But when we want to know about forces, we can predict them from the kinematics. So when we combined biomechanics, which are those kinetics, and then add in our different factors like body mass and dampening elements, that can help us to predict the actual impact force. So we can use kinematics to give us information and predict our kinetics. And really, the $1,000,000 question is how do these, well, and from what we saw, $1,000,000,000 question, how do these mechanics relate to injury? So they've done studies over studies and more studies and reviews of those studies to say that there isn't really a predictive nature on looking at someone's gait mechanics and knowing how they're going to get hurt. We can't necessarily draw those conclusions at this time. However, when someone has an injury history, there have been connections with certain gait mechanics. So it's probably best suited to be looking at someone's mechanics with the lens of what injuries they've had in the past. So, for example, if someone has had IT band syndrome or patellofemoral pain, we should be connecting these things to things like hip adduction, internal rotation, and pelvic drop. However, we can't go the other way around. We can't guarantee that if someone has pelvic drop, they're going to have IT band problems. Things like tendinopathies can be related to eversion, and bone stress may be related to overstriding. Higher vertical forces can be connected to patellofemoral pain and plantar fasciitis. So in this second section of today's course, we're going to talk about some of the most common injuries. So the sites of injuries, of course, the knee is at the top of the list with lower leg. Foot and the upper part of the leg are also on the list, followed by ankle and hip and pelvis. So we'll be talking about some of the most common ones at each of those areas. One thing I just want to highlight is a runner is not a runner, right? It's not a thing where all people who do this activity are doing the same. And I think we should point out that all of the gait mechanics we talked about, all of those overuse strategies we talked about, those were all geared towards endurance runners. So when we're talking about sprinters, we're going to be talking about different mechanics, different risk factors. They're not going to be in the same categories. One of the things that they've looked at is who is most likely when it comes to different kinds of runners. And they found that it's a U-shaped curve when it comes to distance. So runners who are over here on the shortest side of the spectrum, so these would be our sprinters, have the highest rate of injury, which is actually similar to our runners who run the longest distance, our ultra marathoners on the other side of the U curve. So our most likely to get injured are our shortest and longest runners. But we find that even though they're both at the top of the curve, they get hurt with different injuries. So if you think about, all of the Olympic races that you watch on TV, or if you've been to track meets or work with sprinters, the hamstring injury, right? The hamstring tear, the hamstring strain, those are the things that come up as the hallmark injury of a sprinter. This is because runners who are in those shorter, more explosive distances have a greater reliance on their proximal muscles for power. So we see higher glute activation, higher hamstring activation in our sprinting mechanics than we do in our endurance runners, hence the hamstring tears. When we have more endurance running, we have an increased reliance on the distal component. So that's why we're talking about things like the gastroc and the Achilles, and why we see so many endurance runners who have Achilles injuries. The first category of injury we're going to talk about is tendinopathies. So tendinopathies are a classic overuse injury, which matches quite well with the activity of today, which is very repetitive. Depending on which type of tendinopathy we're working with, really this pattern fits for all of them. So we get a repetitive stimuli, which takes us to the tendon being loaded beyond the physiological tolerance. And I just want to reference back, right, our stress strain curve. So if we go above that curve in this section, that's where we're going to start to get that tendon loaded beyond its tolerance. And the result is degeneration of the tendon. That's where that tendinopathy terminology is going. Again, across the different areas of tendinopathy, this is really consistent for all of them, whether it's Achilles, whether it's patellar tendon. We get an increased thickness. So I'm sure you can picture like the Achilles heel that's gotten that thickened chronic tendinopathy look. The normal collagen architecture changes and becomes more disorganized. I love the visual for my patients of spaghetti when I talk about tendons. So sometimes I'll describe the analogy of raw spaghetti. So when we have a tendon with really beautifully organized collagen, it should be a box of raw spaghetti noodles. They're all just stacked in next to each other. Everything is aligned nicely. And then I say, having tendinopathy is like cooking your spaghetti. Now we have this bowl of messy noodles that are all going along with each other. So when we're talking about the rehab, I said part of our goal is to try and reorganize the tissue so that our collagen can become more like raw spaghetti again. Our tissue level then kind of goes down to get a resulting increased cross-sectional area and then reduce tendon stiffness. And of course, stiffness sometimes get a bad rap of being like inflexible, but when it comes to a tendon, we actually want stiffness because that viscoelastic property is what stores and produces our force production. Then our management strategy also is fairly similar along all of these different processes. We've got the initial goal of managing symptoms, reducing load. So I always tell my patients that this is the phase where we're going to calm it down, right? Things right now are angry, they're irritated. Our job, step one, calm it down. So that's where we're doing that sometimes with offloading strategies, sometimes with pain reduction strategies, but we need to kind of break the cycle. Then we can focus on recovery. That's where we're going to start to go through these reorganizing type of exercises. We're going to try and get things to actually start to remodel or change. This rebuild, we need to take this slightly remodeled tissue, we need to make it better than it was before. And then finally, we need to actually reintroduce activity. Our first area of tendinopathy that we're going to talk about for this population is in the Achilles. So this is coming from excessive gastrocsoleus loading. There can be a few different factors that make that more likely. One would be terrain. So the running on sand can actually increase the power needed from the gastrocsoleus. Also, the race distance. Now, the reason race distance really matters is because of the speed. So when we're talking about shorter races, we tend to see a higher risk of Achilles issues because they're running faster. And we also should differentiate in the Achilles between mid-substance and insertional tendinopathy. Mid-substance being that 2 to 6 centimeters above the calcaneus, that has slightly different risk factors than the kind when we're talking down here at the insertion. The insertional tendinopathies have that much higher component of compression as a factor. So that can come from things like footwear. It can also come from a bunch of uphill running because you're an increased dorsiflexion. So as we talked about with inclines. And then also anatomically, if someone has that Haglund's deformity or that kind of pronounced posterior bulging of the calcaneus, that can also increase the compressive forces of the Achilles tendon. When we're talking to these patients in the clinic, what kinds of things might we hear them say? Usually it's a gradual onset. It's not that someone was perfectly fine one day and is absolutely horrible after that. It's more of a thing that creeps in over time. They might start off with some stiffness, pain with palpation. Early on, it might kind of warm up during a run, but as it gets more severe, usually they kind of lose that ability to have it go away. And they'll typically end up with a deficit in strength or performance. When you see them in clinic without the shoe and sock on, you'll be able to see that spot of pain right here in that 2 to 6 centimeters above the calcaneus. You may see thickening based on how chronic it's been or how inflamed it is or irritated at the time. They likely will have pain with palpation of the tendon there, but there are a couple special tests you can use as well, and those are located here at the bottom of the list. So the Arcsine and the Royal London Hospital tests are really used to differentiate between tendon issues and some of the other structures in this area. Because yes, we have the Achilles tendon on the back, but in addition to the tendon itself, you can also have an issue with the sheath, so the actual surrounding of the tendon, or you can have an issue with the bursa at the back. These special tests are trying to differentiate between those, and really they both have in common that they're locating the site of pain, and then they're going through the range of motion of dorsiflexion, plantar flexion with the foot. And as you do that, the tendon itself will move because of the contractile component of that. So if the pain moves, that's more indicative of tendon than if the pain stays stationary as the tendon goes, which would be more indicative of one of the structures like the bursa or the sheath, which don't have mobility. Other things in the evaluation of this patient that you would also want to consider are things like deficits in hip neuromuscular control. So this is one that I really like to include in most of my Achilles rehab evaluations, is how is the posterior chain system working together? We've got push off happening, many, many times a minute. Is the Achilles carrying the burden of the push off propulsion? Are the glutes helping? Are the hamstrings helping the way that they should? So that's what that hip neuromuscular control is really talking about. I always try and look for what I joke about as being the sleepy glutes. Do we have strong glutes or weak glutes that aren't kicking in and helping the Achilles and the gastroc complex out the way that they should? Range of motion can also matter in the ankle joint and the subtalar joint. Pronation, and then body weight. The more a patient weighs, the more stress and push off and those impact forces that are going to be happening. There are no shortage of strategies and common interventions that people have tried for the Achilles. This is listed on the top to bottom here. So from essentially like the least invasive to most invasive in some ways. That's actually probably not true because I'd put orthoses above injections in that way. But the least invasive is at the top and the most invasive is at the bottom. So wait and see. Of course, just do nothing and see if it goes away. Exercise therapy, though, having that asterisk there as being the most strongly supported by the evidence. Injections, shockwave, orthoses, medications, and surgery are also commonly utilized. But I think what's interesting and worth thinking about or even talking about with our patients is the prognosis of Achilles tendinopathy. Looking at the timing, we're not talking weeks, but that is a timeline of months. So 3 to 12 months after beginning treatment is when a patient would expect to see resolution of symptoms. So if someone is coming into you with Achilles tendinopathy, it's probably not realistic to give them that 6 to 8 week timeline, because quite realistically, they will get frustrated and then consider themselves to have failed therapy when they really should have given it longer based on the prognosis. I also thought it was quite staggering, actually, when I read this final statistic that said that 10 years later, chronic symptoms still persist in about 25% of patients. So 1 in 4 people with Achilles tendinopathy are still having pain 10 years later. A lot. So it's also something to just kind of think about when it comes to patient expectations. With that exercise being the most evidence-supported intervention that we have, it's really important to talk about, well, how do we do that? What kind of exercise should we have? There is plenty of research out there looking at the protocol for Achilles tendinopathy. So I always think of it as kind of like a name salad because we've got Silbernagels, Alfredsons, Stanish. There are all of these really identified, laid out programs for all of the different ways of loading. And I think what it really comes down to is this piece at the bottom, which I actually found quite reassuring to myself because I think keeping up with all of the different protocols can be really daunting. This one here says, any type of muscle contraction has been shown to essentially be effective as long as we're mechanically loading the tendon. So if it's progressive and it's based on patient response, you should get the results that you're looking for. So it doesn't matter if you're choosing the first one on the list, the third one on the list, the fifth one on the list, as long as you're being progressive and you're basing it on your patient response, that mechanical load of the tendon is really the important component of the program. So it's a little bit more dealer's choice. Patellar tendon is the second area we'll talk about with tendinopathy. This one, of course, due to the repetitive eccentric loading of the quads as you're going through the gait cycle in that loading phase. This patellar tendon pain is actually more commonly referred to as jumper's knee, not runner's knee. So hence the reference to Michael Jordan. Michael Jordan is a staple in our household. There's actually a poster of him next to my husband's nightstand, as he has loved Michael Jordan since he was a child. So jumper's knee is commonly referred to as this type of tendinopathy. We're seeing pain usually at the attachment of the patellar tendon, the inferior pole of the patella. And this is one that's going to be typically just painful during higher energy activities. It's not one that's usually bugging people as much in rest conditions. But factors that contribute will be muscle weaknesses, foot postures, decreased motor control, or faulty running mechanics. But it is important that we're good at our differential diagnosis because there are other structures in this area that can mimic patellar issues. However, they might require slightly different interventions. So in thinking about that anterior knee pain, other things that it could be are intrapatellar fat pad issues or inflammation. It can be chondromalacia patella and also plica syndrome. I think when you're trying to differentiate with plica, one of the things that is sometimes the most insightful is whether someone has pain in the area with unloaded or non-weight bearing flexion and extension. So if someone is elevating, like hovering in a straight leg raise and then does flexion and extension with the knee, oftentimes that's something that's going to be provocative for people with plica syndrome, where it may not be with people who have patellar tendon pain. So to manage patellar tendinopathy, there are multiple different strategies on this list, but strengthening is really going to be the hallmark as well. Starting with those isometrics in the calm it down phase. So when we're in that kind of early one where we're trying to curb our symptoms, isometrics is really where we're going to begin. Once we get past that point where someone's pain is really kind of running wild and we're ready to get into that recovery type of mode, then we're going to be looking at high reps and low weight. So more of that eccentric maybe program, or ones where we're really looking at rep schemes like 15 to 20 reps. Then once we get past that and we're in the rebuild, so let's make it better and stronger than it was before, then you're going to transition into the low reps and higher weight. Then to kind of fill out that cycle, so there are 4 steps, right? We calmed it down, we recovered the strength, we rebuilt to be bigger. The last box on that continuum was return to sport. So that's the piece where we come down here to the bottom of the slide. So we need to assess the technique for the actual activity that someone's going back to. We can't just have someone do a bunch of squats and then send them out to impact activity and hope everything goes okay. We need to be looking at things in their actual mechanics of the provocative sport. So in this case, we're going to be wanting to think about things like vertical displacement and overstriding. And I think this is probably a good point to back up and define overstriding because we've talked about it now a couple times. So overstriding is defined in running as having an increased distance between the center of mass and the point of initial contact of the foot. So when someone is really landing far out ahead of them, that's the first component. Then from that, we're also looking at an increased braking impulse. So if someone is having an significantly increased dorsiflexion angle, that'll also be a component of overstriding, and these things combining can have a really big braking impulse, which can impact things like patellar tendon. I guess I should probably back up here just for a second to mention the manual therapy. So this does have a role early on. It's not necessarily going to be what remodels the tendon, but early on in that phase where you're trying to reduce pain, it can be helpful to do either some sort of cross friction or instrument-assisted mobilization. And in the muscle tissue, if they do have some sort of increased tone, dry needling can be helpful, or soft tissue mobilization to try and restore that. There are some additional strategies that can help with some of those general goals on the previous page. So if someone is having a difficult time moving into heavier resistance, blood flow restriction training, or is oftentimes referred to in the clinic as BFR, that can be helpful to help increase tolerance for heavier or more regenerative loading without having to put it into as much pain. There is some evidence for extracorporeal shockwave therapy for patellar tendonitis or patellar tendinopathy as well, but there is no evidence for ultrasound, phonophoresis, Orianto. So if those are things that you've historically done in the clinic, currently those don't have an evidence foundation for them. The literature also does speak about infrapatellar straps. Classically, we see the patellar tendon straps. I find that people throw those on for pretty much any kind of knee pain, but it's actually intended for patellar tendinopathy. It does show in the research that early on in that pain reduction phase, those may be helpful for improved tolerance for activity and proprioception. Transitioning away from tendinopathy, then, I'd like to talk about bone stress injury, because this is a population that sees a very disproportionate amount of bone stress injury compared to other populations. So in runners, the site most commonly talked about and most commonly experienced for bone stress injuries is the tibia. So with tibial stress fractures, we're talking about the etiology of this being a loss of shock absorption due to muscle fatigue. So the load is actually being transferred to the bone. The other thing that has really been a focus of the literature in the last year or two, it's probably the last 3 years, is the concept of the repetitive muscle contraction. So originally we had talked about load on bone, that loss of the shock absorption. But now they're starting to learn more and more that actually some of the bone stress is from the high muscle activity that's pulling on the bone when the impact is occurring. So the actual muscle contraction and that stress on the bone can be a contributor to the underlying stress fracture as well. When the bone is not able to remodel, then that's when we start to get this breakdown. And again, if we were to just kind of go back to our stress strain curve, so if we have insufficient time to remodel or our loads are too high, that's going to put us above the curve in this category of injury risk. There is somewhat of a continuum when it comes to bone stress injuries in the tibia. On one side, we've got the medial tibial stress syndrome, also often referred to as shin splints. And then we go on the continuum and we can get a full stress fracture. So they're really in some ways on the same pathway. How do we differentiate the two then? So our medial tibial stress syndrome is typically more vague and more diffuse pain along the middle distal tibia. The area is often referenced as being about 5 to 10 centimeters. So we're talking about having a little bit more of a global area that's impacted by this pain. If we're comparing this to a stress fracture, oftentimes people will point with one finger and say, this is where it hurts. That is very different than our people who have an area or a region of pain. Sometimes we'll get that similar pattern to tendinopathy where the pain is worse at the beginning and then starts to gradually subside. And after a run, people will feel better. As it worsens, though, we'll often see, similar again to tendinopathy, that the pain does persist even past activity. In comparing to the tibial stress fracture, we talked about the localization. We also see, though, the role of imaging when it comes to confirming a tibial stress fracture. The difficult part, though, about using imaging is the fact that radiographic evidence doesn't typically show until there's at least 40% compromise of the bone structure. So these early stress fractures oftentimes won't show up on radiographs. The other concern with the imaging is that typically the symptoms are going to precede imaging results for 2 to 3 weeks. So if someone is coming in with shin pain with a 10-day onset, we would anticipate that it's actually too early for it to show up on x-rays. So because of this, what you'll often see in the clinic is that providers will get and order x-rays. However, if they're negative, they'll still assume a positive diagnosis for stress reaction. They'll just qualify it as an earlier or less progressed version of the injury. An MRI can be used, though, to pick up these earlier cases or ones that are more subtle on x-ray. These would be considered the gold standard for diagnosis. Clinically, a HOP test can be used to try and identify the response to impact loading. When it comes to managing it, really, of course, the first thing we need to do is manage the load by trying to reduce the stress that's on the bone. Sometimes it's done with a boot, sometimes it's done with crutches, maybe both, similar to the picture here where they've stacked up both, and using relative rest. So this is a really important thing for our runners. I think the word relative, a lot of them are really used to or accustomed to being daily exercisers. So they may be running every day, they may be running most days of the week. It can be really hard to convince them that they can't. So instead of doing that, we can sometimes rephrase it as this is a period of cross training. This is an opportunity for us to train in another way to address and prepare you for being a better runner when you come out of the boot. Um, I love using that time for core training, proximal hip training, things like that. There are some options often for non-weight bearing cardio if someone wants to use a UBE, like an upper extremity ergometer. Occasionally, some physicians will clear pool related activities. So you just have to kind of work with the medical team to try and identify what is appropriate or acceptable for bone loading at that time. There is some evidence as well for low intensity pulsed ultrasound to help with supplementing the bone healing process along the way as well, depending on access to those resources. How to decide when it's time to go back to running. So this is a part where I think the rehab team has a huge role on the medical team. Usually stress fractures are going to have a physician involved in the management. However, I've seen many, many times where once they see appropriate signs of bone healing, they tell the patient, you are cleared to return, which I think is a really risky phrase to tell a bunch of runners because they are used to putting on a lot of mileage. So when a physician says, but start slow, I have had patients who, there's one that comes to mind in particular from about 4 years ago, who had been training for a half marathon, ended up maybe about 8 or 10 weeks into her training program being diagnosed with a metatarsal stress fracture. And she had been running about 10 miles at a time. When her physician told her to start back slowly, she started with 8. By the time she got to me for her first PT appointment after that doctor's visit, she told me she went back slowly by starting at 8 miles. I think as PTs or OTs or the practitioners on the rehab side of this program, being able to really quantify to our patients what a slow return to running program looks like is really valuable because their perspective of what gradual looks like might be very different than what their tibia thinks is gradual. So a few things to be looking for. Usually we need to see at least 5 consecutive days of pain-free ADLs before we would do any kind of graduated loading program. We want to make sure that we're looking at their form. If, of course, there are any underlying characteristics that are predisposing them to this injury, we want to make sure to take care of those so we don't go through all that immobilization time and relative rest time for nothing. It's a good time to be talking about what kind of footwear they might need or orthoses they may need in order to really get our best outcomes once they return. And this brings me to a very relevant case study or case example from my own practice. This was when I was an adjunct faculty at a program in Louisville. I set up a runner's clinic for like a teaching runner's clinic in one of their on-site clinical programs. And in that, I had the privilege of working with a 20-year-old cross-country runner who was part of their Division I team. She had pain in her shin for about a year and a half. She had been evaluated by her sports medicine physician, which was through the university, but then she also, due to the duration, had gotten a second opinion at her orthopedic facility at home in Indiana. She had gotten radiographs, she had gotten MRI, and they confirmed that she had had a tibial stress reaction. They really had a comprehensive approach. They did a really good job of trying to identify not just the problem, but the cause. So they had done a bone density scan, which was normal. They had her consult with dietetics to make sure that she was getting all of the nutritional support she needed. And she had to sit out the remainder of the season. During that time, they had her do physical therapy. This was before I was on site. So she was doing physical therapy with an orthopedic team. They worked on strength and flexibility and balance. They had her switch to a more cushioned shoe so that she was absorbing a little bit more shock. And over the off season, she got significantly better. So due to the improvement, they cleared her to resume training with the team the following season because she had done a very progressive, really nice and graduated return to running program. Unfortunately, what happened with this patient is her symptoms came back really early in the season. They sent her right back to physical therapy. They switched her to cross training to avoid that impact and protect her tibia. And then when her symptoms were better, they slowed down her return to running program even more. So she was now on a program that was really, really tiny amounts of running, a lot of walking, a little tiny bit of running, and it was really slowly progressed over time and really disappointing to her, even though she was an incredibly compliant athlete, her pain still returned. So at that point, they decided they needed to redshirt her. And by this point, I was then on site at the university. They referred her to me to do an evaluation. So when we did our evaluation in our student gait clinic that we had at the university, we were identifying really what her baseline was, given that she had already done all of this PT and her return to running programs. So we identified that anatomically, she really was as good as she could be. She had a 5 out of hip abduction and extension, which I think we all know is pretty rare to come across, like a true 5 out of 5 hip abduction and 5 out of 5 lower abdominal strength. So this runner really had been compliant with her program and really worked hard over the year and a half leading up to when she saw us. Posturally, she really didn't have any deviations we could point to. She was neutral through her hips, knees, and ankles. So that really took us to that last bucket, which was her mechanics. How did she move? So we were looking at her overall gait mechanics and identified that she really did have that overstriding pattern. So she had an increased distance to her center of mass from her initial point of contact, a decreased knee extension at initial contact, and she had increased dorsiflexion at initial contact. So overall, that braking impulse had a strong carryover or association with tibial stress reactions. So we decided that that was an appropriate clinical pattern to try a gait retraining with an increase in cadence, because we know by increasing cadence, some of these factors are the ones that resolve. So we did a very gradual interval treadmill training program with her at a 10% increase in her cadence, and also partnered that with some desensitization, because the desensitization for her was a way of really calming her anxieties about it coming back and to really try and recalibrate the signals that she was getting from that tibia. Fortunately, after going through that whole program, she was able to resume training with her team at the beginning of the season. And checking in with her throughout, she was actually able to successfully complete the full season with her team without a recurrence of her pain. So really building on all the anatomical things that they had worked on and the training things that they had already established, we were able to bring in that biomechanical piece with gait analysis and create the outcome that she needed. Just as an acknowledgement of other sites of bone stress injury, it is also more common in the running population than others to have femoral stress reactions. This one is often one that has a slightly more delayed diagnosis because of the way that it can mimic general hip pain from things like impingement and labrums. But if you have a runner with a history of a stress fracture in another bone, or any runner who's had a training change and then presents to you with deep hip pain, this is something that we really want to have on the radar. I always kind of ask my patients, can we touch your pain? If I can push on your pain, if I can push on your TFL, if I can push on your glutes and I can make your hip hurt, maybe then I don't have as much need to be concerned. But if that pain is deep, we need to be considering femoral stress reaction. The other bone of concern is the metatarsals. The metatarsal stress reactions are most common in the second and third digit. They're going to have issues with forefoot weight bearing, might not be able to toe walk. Really, if we're talking about someone who locally points right here and says it hurts, or points right here and says it hurts, those are the ones we're going to be most concerned about. I think differential wise, we're probably talking the most between this and something like a neuroma. So if we're talking symptoms that are more neurologic sounding, then we're going to be looking for other types of causes. When it comes to patellofemoral pain, now we're speaking about what's classically termed runner's knee. So the patellar tendon tracking coming together with the high compressive loads for running, causing this more joint related stress compared to our patellar tendon stress. The evaluation of patellofemoral pain, the most classic sign is just going to be your retropatellar or your peripatellar pain. So essentially people are going to tell you your knee hurts around here, your knee hurts around here. But the most reproducible activity for that pain is often squatting. In the research, it shows that there's a sensitivity of 91%. So if someone can squat and doesn't hurt, there's that 90% chance you can rule it out. It doesn't necessarily have good specificity that if someone has pain with squatting, it is for sure patellofemoral pain syndrome. However, if they're negative, unlikely that this is the problem. There are other clinical tests that go along with this. Some of them, though, are really more exclusionary. So when we're talking about patellar apprehension, we're trying to rule out patellar instability. When we're talking about ones like patellar compression or palpation, those are more related to actually having patellofemoral pain. The things in general, diagnoses that are on that differential are things like meniscal injuries or ligamentous injuries, or probably more commonly patellar instability. The evaluation includes a few different categories, everything from strength and flexibility, which are more those anatomic, to again our how we move bucket or mechanics. We know that these aren't necessarily proven to cause patellofemoral pain. However, we have seen associations between these characteristics and patellofemoral pain. So strength in the quads, and importantly to note the hips, of course, flexibility really across all of the major categories of the limb, but I think most notable, the lateral structures of the TFL and the IT band. And then in our mechanical evaluation, we want to, of course, look at their running mechanics, but we can also tell a lot from their squat and from their step down due to the loading nature in that eccentric quad. The management strategy for patellofemoral pain syndrome really is still a loading strategy for the muscles. So when we're going through that, we're strengthening the quads and the hip rotators. So the progression for the quads that's best supported in the research at this time is to begin with low load muscle activation in that early phase where we're looking at pain reduction. So that might be things like wall sits, isometrics, might be straight leg raises, could potentially be something like the leg press, ones that are going to be low load and under a lot of control. Once things are going well with that from a pain perspective, and generally speaking with their ability to accept load, then we can go into our multi-chain control and coordination. Since there's such a component with patellofemoral pain on alignment, not only do we have to be able to integrate that muscle activity, but we have to be able to do it with optimal mechanics. So this is where we're going to be switching some of my go-to exercises in this category are going to be the lateral step down, because then we get kind of that single load where you have to have pelvic control at the same time. I think lunges can be really good. As you progress, even lunges to an unstable surface like a Bosu ball can be great. And then finally progressing into our impact component and being able to control the landing mechanics with plyometrics and propulsion. So this will be a time where you might be progressing to things like line jumps, maybe doing a box progression where you're doing box jumps or squat landings, things like that. That is going to take you through the progression of safe loading to activity that resembles their running mechanics. In the gait retraining category, you're going to be looking for hip adduction and internal rotation as well as pelvic drop. Anything that's really taking the tracking and moving it medial. So just like we would for other people with patellofemoral pain, just under higher loads. Some things that go along with this process as we're trying to calm everything down. Sometimes manual therapy is helpful, especially for the soft tissue mobility of the lateral structures. So really doing manual therapy through the lateral retinaculum can be really useful to try and make sure that that patella has the ability to glide into the femoral groove the way that we want it to. Modalities can sometimes be helpful, specifically taping. In the short term, taping might give a little bit of that proprioceptive cueing that we need in order to maintain some of that neutral alignment. Plantar fasciitis. This is a common one amongst the running community for sure, especially the aging running community, which we know is growing as well. So much so that sometimes I've had patients come in to me and tell me, oh, I know I have PF. And I thought to myself, plantar flexion? Don't we should all have plantar flexion. And then to realize that they in the running community have actually affectionately just started referring to this as PF because it's so common. Plantar fasciitis really being a degenerative process of the plantar fascia, really being a factor in runners most of the time because of this heel loading. So we know that during initial contact, a heel strike can absorb up to 3 times the body weight in impact forces. So there's a lot of load going through here on a very repetitive basis. The ability to absorb the load is going to be dependent on not just the plantar fascia, but also the plantar fat pad and the intrinsic muscles of the foot. Age has a factor in this because not only is the prolonged nature of repetitive use a factor, but also the absorbability of these structures can change over time. The presentation is often going to be pain at that medial heel, most notably those initial steps after a period of inactivity, those first 5 steps when you wake up in the morning, or if it's someone who sits a lot at a computer, might be after they've been there for a while, maybe after they watch a movie, something where they're prolonged inactivity. The pain is often reproduced with this palpation or with the windlass test where they're pulling the toes. That's what's depicted here, that windlass maneuver where you're pulling the toes back, putting the tension, the passive tension on the plantar fascia. Those can be good things to identify that there's some causative nature there with the differential diagnosis listed on the bottom. And I think in runners, we do have to think about some of these other ones quite often. I can think of a specific patient that's a good example of the insertional tendinopathy who was a triathlete. So triathletes are often running in their designated leg of the race, but they're also running often during their transitions between run and bike and swim. And during those periods, they're often running in non-traditional footwear or on some non-traditional surfaces. So in this particular case, it was an Ironman triathlete, and she was running between the bike and the run in bare feet to get to her running shoes. And during that time had a flare up then of symptoms for months afterwards. And after we cleared out any plantar fascial pain, what we realized is actually she had developed an insertional tendinopathy of the medial ankle flexors. So those were part of the issue in addition to the plantar fascia. So just making sure that you get some of that differential diagnoses between the two. Management strategies at this time, really the best supported for plantar fasciitis is stretching of the plantar fascia and the gastroc-soleus complex. Manual therapy can provide some benefit if we're looking at joint mobilization for the ankle, specifically into dorsiflexion, or doing soft tissue work for the gastroc-soleus. Personally, I do find quite a bit of impact for patients from taping, utilizing anti-pronation techniques. There are the classic Lodi taping techniques for the plantar support surface of the foot. However, I think it's a lot faster and more efficient to be using some of these anti-pronation techniques. I'll often even use the kinesiology style tapes with the stretch, even though they're not holding someone in an arch supported position. It's enough cueing to help them to really try and attain a better foot posture. Education is supported on load modification and footwear and orthoses as well. So thinking about heel cushion and arch support as being the primary things to look for in these orthotics. Sometimes patients will be asking about the quality of orthotics and whether it matters if they get custom, which might be north of $400 from a podiatrist, versus maybe a shoe store version, which might be $50 to $70 versus an over the counter. And what they found is that some of those lower cost orthoses are actually just as effective in reducing symptoms as some of the more custom ones. So I'm usually steering my patients towards the cheaper things to see if they can get some results before considering anything more obtrusive. Night splints also have good results if you have a patient willing to comply with them, because of course they're kind of an intense thing to try. And then modalities right now, the best supported for plantar fasciitis are Ionto, low-level lasers, and Phono. In addition to that, there is some evidence for minimally invasive interventions. On that list is shockwave therapy. There's also some evidence for injections, and there are two different ones listed on here, corticosteroids and PRP, or platelet-rich plasma. I would just kind of like to highlight this one right here, increased risk of plantar fascia rupture, especially in our patient population of runners. The increased forces that we see, that 3 times the body weight, I get really squeamish about recommending someone talks about corticosteroid injection, just because that plantar fascia rupture would be catastrophic. So we really want to try to avoid that. If someone is looking towards injection and has the option for PRP, maybe having a lower risk of plantar fascia rupture might be a good consideration in that case. There are a few other conditions we're just going to breeze through quickly here because they're not necessarily the most common, but yet in this population, they're more common than we see in other places. So the first one is iliotibial band friction syndrome, or oftentimes IT band syndrome. These being inflammation or thickening of the IT band with excessive fluid there, either from compression or friction, kind of some debate on those theories. You're going to have very similar presentation and etiology to patellofemoral pain, with the treatments being similar, although a greater focus on the hip component. Because that IT band originates up by the TFL and glutes, we want to just spend more time up on those lateral structures and then working our way down the lateral quad. Compartment syndrome, exertional compartment syndrome as well, is something that we see more in runners than other populations. And this being that reversible version of fascial compartment pressure. So compared to traumatic acute compartment syndrome, this is one that comes and goes. So the acute kind is an orthopedic surgical emergency where that pressure needs to be immediately released before we get neurological death or compromise. In this case, we're getting symptoms that come on at a pretty predictable point in the run and then resolve when activity is gone. The thing that kind of should trigger you to think about compartment syndrome is if we're getting any kind of neurological distribution. So if someone is starting to talk about getting numbness or tingling, someone is talking about getting temperature changes, like they're getting cold from vascular constriction, we want to be thinking about whether this could be compartment syndrome. And really, this is going to be identified by doing compartment pressure testing, which is why I have this wonderful picture of a thumbtack up here, because they are quite frankly having someone run on a treadmill to the point where they're symptomatic and then sticking needles to gauge pressure in there. Sometimes you can do some activity modification to make it go away. Other times they will need to do surgical intervention for compartment releases. And then finally, the last one I wanted to talk about was runner's dystonia. And although this doesn't fit the list of being most common, it is unique to them and really something that has gained more press and attention over the past 5 to 10 years. This is a task-specific focal dystonia with that overflow muscle activation. I always think of it as being more of a neurologic confusion when it comes to a task. Essentially, you do something so many times it becomes awkward. Kind of like, I think we've all played the game as kids where you say a word so many times that it starts to sound funny, right? Like if you say water bottle, water bottle, water bottle, eventually it starts to sound weird. That's kind of the neurologic version of dystonia. So in runner's dystonia, the actual participation in the gait mechanics becomes in a kind of dysfunctional pattern. There's no definitive treatment for it. You can try and use Botox to get the paralysis of the overactive muscle. physical therapy to maybe try and do some motor pattern confusion or pharmacological treatment. And I actually did have the privilege of working with a woman with runner's dystonia, which at the time there was only, I think, less than 24 cases in the country that were documented. But it was a really cool opportunity to really see this in play. So I just wanted to spend a minute here of our time going through it to give you guys an example if you haven't seen one in your own clinic. It was a 60-year-old woman who came in with a chief complaint of left foot drop. She had kind of been through the diagnostic gamut. She'd been to spine, she'd been to ortho sports, and essentially they ruled out all of the things that foot drop would have come from. On their remaining list of differential diagnoses was a neuropathy, a radiculopathy, or a motor neuron disease. So the ones like MS or ALS. But they couldn't really find any evidence for any of those things. So they sent them to PT and said, gait analysis, left foot drop, we don't really know why. So she had told me when we did this objective that her foot would scuff when she would run, her leg would kind of hiccup and stop and sometimes cause her to trip, but she had no pain at all with anything. She had been experiencing it for about 3 years, and she was about a 30-mile-a-week runner, always running in her neighborhood the same loop. And she felt like it was getting worse. So in taking a look at this, she had no postural abnormalities, no muscle abnormalities. Everything was strong. So despite having foot drop, she had full 5 out of 5 strength. She had no classic neurosigns like her clonus and spasticity were negative. Functionally testing her, she could heel walk, toe walk, she could hop, she could do anything when she wasn't running. So then we did the gait analysis. I did it twice at 2 different points in the run. Her cadence was fairly low, but the most telling things were that her foot strike patterns were different. She had initial contact heel strike on one and foot flat on the other. And the other thing that was really more influential in the diagnoses was what happened in the anti-gravity phase. So when she was in swing, one foot was in neutral, like neutral dorsiflexion, and the other one was plantar flexed. So it was almost like her foot was in a spasm when she was in the swing phase. And to me, that was identifiable to the overactivity of the plantar flexors in swing phase. So she did go through a little gait retraining program. We tried to do some sensory tricks, having her do things like running on trails. I talked to her about changing her cadence. She wasn't really interested in doing a ton of changes. She got a little bit of improvement on trails, but otherwise this is something that really was something that she just had to kind of go to support groups. She was finding some online people to talk to and really gave her more of a peace of mind that she didn't have a greater neurological problem. All right, so this third and final portion of today's course is going to be on really our specific strategies for rehabbing the runner. So how does transitioning this person back to activity look different maybe than someone who does a different type of lifestyle? Maybe they're someone who's more sedentary or someone who chooses non-impact exercise. So the first of them we're really going to talk about in depth is gait retraining. So with gait retraining, we have different target metrics. Are we trying to change their cadence? Are we trying to change their mechanics or their muscle activation or their foot strike? We have to decide what is our target. Then this is a question we talked about earlier in the course, treadmill versus overground. So I do really steer my patients in a gait retraining program towards the treadmill, even if they're primarily an overground runner. One, because of that nature of standardization. So we can have them set no incline. We can have them set a specific speed. And I know that they're going to stick to that, and we're not changing other incidental variables at the same time. And then the other component of that is our tap out option. So when we're on that treadmill, if something doesn't feel like we want it to feel, something doesn't go the way we think it should go, they have the option just to hop off and cross train on a bike or hop off and do an alternate activity versus that overground program where people are a little more tempted to kind of stick it out because they might be far away from home or don't want to have an alternative way to get back. We do want it to be very progressive with gait retraining. I think sometimes people underestimate how much muscle activation changes when we do a gait retraining program. And in that, we need to think about it almost like we're building up a return to running program with gait retraining. So if we're running, let's say 30 minutes, and I want someone to increase their cadence, I don't expect them to increase their cadence for 30 full minutes. I might tell them every 5 minutes, I want you to check in for 30 seconds to a minute on your turnover rate. And then each 5 minutes, I want you to check in again. And then over time, we want to build up how long you're doing that turnover for. So that's the kind of progressive nature we're talking about, so that the tissues can adapt over time, because we know that running differently is going to feel different and work different with those muscles. And then finally on this side, we're going to talk about feedback. So we've got internal focus feedback and external focus feedback. External tends to be the most effective. So the difference between the two, an internal focus is really thinking about the mechanic itself. If I'm trying to convince, I mean, that's the first step. If I'm trying to appropriately realign someone's patellar tracking, I'm not going to necessarily get the same results from them by telling them to externally rotate your knee, externally rotate your knee. You might actually get better results by having them think on something external, like the sound of a metronome and aligning with that, or might be thinking about using your kneecaps as headlights on the road and you want to make sure that they're shining ahead of you. Things like that that are not necessarily so mechanical. Of all of them, cadence is probably the most famous gait retraining strategy of our current era, as you could say. The way we go about this is to actually look at a percent increase. They found that even a 5% increase can be helpful, so I usually use that range of 5 to 10% to try and get some of these changes in gait mechanics. When you improve or increase someone's cadence by 5 to 10%, we see a decrease in pelvic drop, decrease in adduction, and an increase in initial knee flexion when they're at initial contact. So these are all gait mechanics that we are trying to improve, and by increasing mechanics, they automatically will sometimes migrate in the direction we're trying to achieve. It will also often change the muscle activation patterns, so an increase in cadence will often lead to an increase in gastroc and glute pre-activation or activation. The other thing that typically happens is we reduce the average vertical loading rate. I always describe this as what goes up must come down. So the vertical loading rate, thinking about how high up and down someone's going to go, how much braking impulse they're going to get. I think about it, if you're doing a long jump versus if you're doing a skip, the skip is going to have less force, right? Less landing shock when you hit the ground. So if you're not going as far, you don't have to go up as high to get there. When you increase your cadence, your steps become shorter, which then is more like a skip and less like a long jump. This is the face that some people give me in the clinic when I recommend gait retraining. A lot of runners have been doing it a long time and have been doing it a certain way for a long time. When that happens, they get a little squeamish about making changes. So this slide here is to maybe give you a little bit of a script to help with that, because sometimes when we are talking with them about performance, that's more of a concern really than acute injury. So if we can reassure them that running economy and running performance has been shown in the research that despite cadence and foot strike retraining has been maintained throughout that retraining process. Another tool is actually to utilize speed. So when we decrease our training speed, there is a associated decrease in impact forces. So if we're trying to reduce load on a specific structure, we can do that through decreasing impact forces, which one option for achieving that is decreasing speed. So during this return to running program, teaching or encouraging a patient to decrease their speed can often sometimes also be a difficult sell, because if they're used to running a specific pace, really slowing down may not feel for them like very gratifying running. So oftentimes I'll approach it by saying, we're not using a return to running program as a running intervention for you at this time. Right now, this is a program that we are using to reintroduce load to your tissues. When we do that, we can kind of take the runner out of the run and make it about a reconditioning strategy. So decreasing speed, decreasing impact forces. Recovery is also really important and something that can also be a hard sell. So when someone brings in their training program, this is just an example of a random training program that someone might bring in. It's really useful to sit down with your runner and actually look at when is their rest, when is their load, and does it seem like we're sufficient? Coming back to our favorite injury threshold curve, right? We've got frequency and load. We're going to help them try and identify ways to decrease that frequency in order to keep it below the injury threshold. So it might mean that we're putting longer rest periods between training runs, or really trying to re-engineer the design of the program so that we're getting it to be effective. Cross training. Sometimes cross training can look different. It can be something where we're doing strength, but it can also be doing something where we're doing a different version of aerobic exercise. I think if we're using it truly for an offloading perspective during a running program, it's probably important we're also choosing a non-impact exercise program. I wouldn't substitute running with a plyo program. It'd probably be more likely to benefit if it's something like biking or swimming that's not going to have the same bone load. However, if we're past our return to running program and it's not necessarily a rest day, but it's a training day where we're trying to reintroduce load, then of course plyometrics are great. One of the other benefits that we found is that biking has actually been shown in some of the studies when they compare cross training with biking versus elliptical versus running, like a lighter running day, that those who biked actually had better running performance than those who used other types of cross training. So you can actually phrase it to your team as, you may be able to actually improve your running by substituting some of your running with biking. The question we all need to be asking with our patients is, when is it appropriate to start this return to running program? So how do we know? We talked about this in the stress fracture section, where we want 5 days of ADLs with no pain. Let's really expand upon that. And how do we know? So no days of pain for about 5 is a good threshold, but then also we want to be thinking about what other activity can they tolerate. So if someone is using one of these low impact treadmills, we would want them to be able to tolerate 85 or 90% of their body weight in there before we would expect good crossover to a full body weight program on the ground. We also want to be thinking about their cumulative foot strikes. So if someone is going to be adding a walk jog program, it may be helpful to substitute some of those for exercise walking that they have been doing during the lead up to that. So we don't want to be going from, let's say, 10,000 steps a day to 15,000 steps a day overnight when we're starting this return to running program. So we can actually have people practice for their return to running program by doing a walking program and then transition those steps over to an interval program so that they have some of that load tolerance already built up. You can also do a little test by doing 2 30-second bouts of running and then monitor for 24 hours for any symptom return. So if somebody can handle those 2 30-second bouts of running, then they may be a good candidate to actually start a formal return to running program. If they have pain or an increase in swelling after those 2 30-second bouts of running, they may want a slightly greater interval of time of rehab and other impact activity before actually starting running. Here's an example of a return to running program that I had created just for someone a little while back, intervals between walking, running, and doing multiple cycles of that. So some of the characteristics you want to be thinking about when you're designing your return to running program, the first of them is the volume. So it can be about 5 to 25% of a total exercise duration if we're talking about an interval program. This is. You don't want the whole program to be running. You don't want a 50-50 split at the beginning. Usually you want it to be less than a quarter of the time. You want that progression to be happening with one variable at a time. So I always think, we want to only be able to point our finger at one culprit if there's a problem. So we're either going to increase the number of intervals or the duration of the interval, but not both. So if you're doing, let's say, a 2-minute walk, 1-minute jog, or a 3-minute walk, a 1-minute jog, you're going to want to, as you progress, either do that same cycle a couple more times, or you can increase it, but I wouldn't do both. You're going to usually continue that progression until you hit the point of continuous running before you really do anything else. A lot of times people will ask, when should I go back to doing speed intervals? When should I go back to doing hill programs? And I really like to work people back towards their continuous program first and then to go towards that. Now, there might be some times where you choose a continuous graduated program instead of an interval. And I would typically recommend that for the person who isn't going to comply with an interval program. There are some patients who will have a really hard time integrating walking and who don't want to do a walk jog interval. If that's the case, truly your best program is going to be the one that the patient complies with. So in that case, a continuous graduated program can work. In that case, we're usually starting with a quarter mile and adding a quarter mile each run. That amount of progression has historically been described using the 10% rule, which is essentially saying that the weekly mileage, when you add it all up, should increase by no more than 10% week to week. So, for example, if your cumulative mileage in 1 week was 10 miles, the next week the appropriate amount would then be 11 miles. So that general stepwise program was historically referenced as how much you could increase without increasing your risk for injury. There was some interest in really challenging that in the research because it was really slow and a lot of people had a hard time really keeping it that slow. So they wanted to know, if I did more than 10%, how much more than 10% can I do before I start to put myself at risk? And what they found is that when they compared a 20% increase and a 10% increase, there really wasn't an injury rate difference. There really wasn't a big change in injury risk until the increase exceeded 30%. So oftentimes I'll let my patients know that 20% was safe, up to 30 is likely okay, but between 10 and 20 is, at this point in the research, shown to have stable injury rates. Technology in running has changed a ton and has evolved a lot over the past 10 years. 10 or 15 or 20 years ago, if you had a heart rate monitor and a watch, like a analog or a digital watch, you were probably at the forefront of running technology for personal running devices. Now, over the past 10 years, the GPS systems on your watches have become more and more common. It's actually pretty difficult to find a runner who doesn't run with a watch that can track their temporal spatial metrics like distance or speed or cadence. But there are also other devices that have become more prominent as well, and these are the accelerometers and kinetic insoles. So the accelerometers, or IMUs, which are initial inertial measurement units, can measure the kinematics, but also the peak positive accelerations. So these can offer more data than just the GPS systems alone, and actually talking about some of the gait characteristics as well. And then the insoles, these are going to actually switch from the kinetic measurements to, or I'm sorry, from the kinematics to kinetics, because now we have plantar pressures and actually looking at how the force is within the shoe. And all of this now technology is available to our runners independently, not just clinically. So what does this really mean, right? When it comes to new technologies, the question always is, I can, but should I? So is more technology more? There is, I sometimes feel like this biker carrying a lot of stuff. I was reading through some of these slides last night with my 6-year old, and she was looking at them saying, wow, that guy's carrying a lot of stuff. I don't know if I would do that. And that's kind of how I feel with technology sometimes. Data can be overwhelming if we don't necessarily have a purpose for it. So I think there's like a two-sided coin when it comes to running technology and wearables. The plus side, we get more data. The data is on things other than just distance, right? We used to just track mileage and that was all we knew. Now we get things on training load that maybe we didn't know before. We're also able to get data from settings that we didn't have access to before. So we used to have someone in the clinic on a treadmill in order to get some of these metrics. Now people can take their technology, their wearables with them wherever they normally run. So if someone is a trail runner, if somebody is out in the elements, running against the wind, running hills, we can actually get data from what that looks like. We can also use it to track how someone's adherence with their gait retraining is. If we have a cadence retraining goal of, let's say, increasing their cadence by 10%, we can actually look at their run history and find out what was the cadence when you were in your last 3 runs. How did it compare to what it used to be? The thing to keep in mind on that flip side of it is we know that some of this data has correlations to certain injuries or certain risk factors, but we know that some of them are not directly related. So we really just want to be teasing through the data to pick the metrics that actually have relationships to known injuries. Another common question or topic to talk about when it comes to athletics of all kinds, but runners included, are the warm up and the cool down. So there is the advice that people are always looking for clarification on. Should I be doing a static or a dynamic warm up? And really, the research at this point, when you kind of look through all of the pendulum swings over time and how everything has evolved, the current ideal recommendation for a warm up program would be an aerobic activity combined with dynamic stretching, combined with some version of sport specific activity. So, in our runners, that might be walking mixed with some, let's say, leg swings, some marches or some butt kicks, and then maybe doing a little bit of jog before they take off. The world of static stretching, it used to be all the rage. Everyone was doing it. I think maybe my prior slide on saying it's still the most employed strength and conditioning exercise would say that it maybe still is. But in the literature, we had found that static stretching impaired strength and power, right? So then a lot of clinicians were really peeling back and holding back how much static stretching they were doing. The latest version of the research is showing us that these effects of static stretching that were really brought to light in that research really only happened when the stretches were held greater than 60 seconds. So those negative effects on strength and power were really minuscule when the stretches were shorter in duration. So now that we have that bigger picture of how static stretching did impact strength and power, we can utilize that to really make better recommendations for our patients. So in our recreational athletes, including short duration static stretching for certain flexibility or to really prep tissues that we have concerns about may be the right choice, because if we're doing these shorter ones, the very marginal difference in strength and power may be something we're willing to trade for a decrease in an issue with a known problematic tendon or muscle. Where if you're working with a really high caliber athlete, maybe someone who is in an Olympic trial, someone who is a professional runner, those athletes may want to prioritize that small, otherwise maybe marginal performance benefit to try and get every last ounce out of their performance. So again, who you're working with is probably going to cater how that message is. And then when it comes to the cool down, so we know that active cool downs can accelerate recovery of lactic acid in the blood. It can prevent immune system depression and promote faster recovery of the cardiovascular and respiratory system. So if you took that in a vacuum, you would say, well, then it sounds to me like a dynamic cool down is recommended. However, that's where we look at laboratory science meeting practical application, because what they do know is that lactic acid in the blood actually doesn't equal the lactic acid in the muscle tissue. There also is no evidence at this point on whether there's any known difference in post-exercise illness, syncope, or cardiovascular systems following a cool down. Similarly, it's not known if there's any actual change in muscle soreness, damage, range of motion, hormones, or psychological recovery from the cool down. So, in the lab, in a vacuum, we know that there's these physiologic improvements when we do a cool down. However, we don't really know if there's any actual practical benefits that come from it. So, I think at this point, it's usually more of a we don't think it hurts. It may help, but we don't have such strong evidence that it helps that we need to necessitate or really strongly advocate that everyone does a cool down. I wanted to transition a little bit after those sections into some of the supportive roles of running. I think when we're talking about this population, it's really important to really consider the whole picture, because there are a lot of considerations that go beyond the miles. And I think the psychological considerations are a big one of those. Treating a lot of runners, you will learn very quickly that the runner who can't run is not a happy person. And really, a lot of times that is providers' early advice to them is to restrict running, and sometimes is truly necessary. So, the research, this is actually something that's been done decades ago. They looked at the psychological state of different runners who were on restriction. And they found that there were signs of distress, and higher rates of depression, anxiety, confusion, overall mood disturbances, and lower self-esteem. And really the rationale for why that happens is because so many runners are relying on that activity as a coping strategy for their overall health and well-being. So people who are dealing with stress at work, stress in their family, oftentimes are using running as a way to purge that stress. Just an example in our own life, in this past week, we have a 6 and a 7-year old, and parenting was challenging. I'm sure no one can relate to that. We're probably the only ones who have difficulty sometimes. But when we were having a lot of stress with that, my husband was like, I'm just going to go outside for 10 minutes, go for a run, clear my head, and come back, and then we can all start fresh. So I think that is a great example of how a lot of people use running as a way to just psychologically reset. So when that's taken away, a lot of these other psychological factors start to be a problem. The other component is the social piece. We know that running is oftentimes something people will do with other runners. So not being able to run means that they're not able to participate in the group. There's not a great way to kind of sit on the sidelines when other people are out for a run. So they lose their social support network. Across the course of rehab, the psychological pathway also has a little bit of change along the way. This is a breakdown of injury to rehab to return to play, and showing how that initial psychological response to a running injury is often filled with anxiety about what's going to happen. Am I going to have to cancel my race registration? Am I going to have to transfer my bib? I'm going to have to defer my eligibility for this qualifier. Um, as well as what does this mean for me financially? What does this mean for a lot of factors? Also, some negative cognitive appraisals, things like what did I miss? What did I do wrong? Thinking about kind of the blame aspect of it. Then in the rehab phase, sometimes people can have motivational challenges when people aren't working towards the actual activity that they're motivated for. It can be hard to keep going. So if I'm not doing my race, what's the point? That's kind of the overall vibe. And then the return to play, there can be a couple different factors. We talked about in our stress reaction D1 cross country runner, how she had that re-injury anxiety, right? So as she started to go into things, she kind of assumed every feeling was going to be the onset of the new problem. So that's a really common psychological state to be in when you're in this phase of return to play. And then also some self-confidence concerns, right? People are used to being well trained, so they're going back and they don't feel well trained. They may also be doing a really modified version of what they used to do. And a lot of people identify as a runner, so when they take that back, they're not really sure how they fit. I have a few examples just from my clinical practice that I thought were great examples to show how running for this population really isn't just running, but it has a greater psychological role in their health and well being. I think the first is cancer remission. So, this is actually for me a group of patients I've had, especially I had a period a couple years ago where a large percentage of my patient population were runners who had gone through breast cancer treatment, now were in remission and returning to exercise. And from my understanding of their care, their oncologists, once they got to the remission phase, had encouraged them to increase their exercise as a way to prevent recurrence of their cancer. So again, low barrier to entry with running, high levels of aerobic activity. A lot of these women were choosing running as their increased exercise and cancer remission. Unfortunately, they're also going through a lot of hormonal changes, a lot of immobilization over their course of the year of treatment. So when they went back to running or to running for the first time, they had musculoskeletal systems that were not necessarily well attuned to run and put them at high risk for having an injury, which is why this patient population was so large at the time. The thing that happened psychologically is when they were injured and unable to run, a lot of them portrayed to me that they felt like that was essentially them being told that their cancer could come back. So by telling someone not to run, you were actually telling them that they may have to kind of face this whole thing that they just beat again. So again, just kind of thinking about how telling someone not to run may actually give them a bigger message that you weren't necessarily intending. The redshirting college athlete, similar to the one we were talking about before, the option to redshirt comes with a lot of other factors, right? That is an additional year of college for someone. That might be deferring graduate school. That might be, not graduating with their same cohort anymore. Those are big factors. Those are life changes for someone, not just sit on the sidelines kind of discussions. I have also worked with a couple, unfortunately, mothers who have lost their children, whose children have passed away. One in particular, whose story I think was really salient to me, was their family would do fun runs together. A lot, they would do little 5Ks or kids' runs. And after they lost their son, whenever she would go for a run, she would feel really connected to her son. So when she was told not to run, she felt like she lost her ability to connect with her child, which is something that I think is really something that transcended her physical pain. So I think when we're talking about the big picture, it's really important for us to understand who our patients are so we can know how they're going to take and what our recommendations really mean for them. And then finally, the post-op bariatric surgery. I think a lot of times, once people have gone through these large weight loss procedures, they're encouraged to exercise. And of course, their bodies have gone through such radical changes that they're accommodating to a whole lot of things. And probably in their previous BMI, were not able to do running. So now that they are able to run, a lot of them see that, similar to the cancer population, as a way to maintain their gains and maintain their success. So when they get injured, a lot of them fear weight gain. And that can be a really psychologically scary and anxiety provoking state when they've already worked so hard to get where they are. So I think these are merely just some examples. I think we could have a whole course just talking about people as holistic approaches to treating them. But I think those are some good ones that highlight the spectrum. When it comes to nutrition, it's a huge part of our running related community. We know that we need to optimize storage of nutrition and energy. We also need to optimize the utilization of it. The whole goal is to prevent fatigue due to nutrient depletion. We don't want to have a decrease in performance because we didn't have the fuel. We also need to minimize GI distress. It's not hard pressed to find a conversation between runners about which courses or which routes have the best distribution of public bathrooms, because GI distress and running is definitely a correlated, associated conversation. and as well as hydration. So these are the overall goals when we're trying to improve performance and meet that with nutrition. Nutritional needs, what do those look like? It's the overall energy, it's the macronutrients, so specifically which types of nutrients are we looking to get, and then vitamins, we need our iron, we need vitamin C, antioxidants, and then some immune system modulation. This is my 6-year-old daughter when she was eating her first try at oatmeal, and she grabbed the spoon out of my hand and gave me that look that was like, I don't need you, Mom. I got this now. She's still very much like that today. But that makes me smile every time I think of nutrition and kind of how we have to learn to eat along the lifespan. But really, when it comes to nutritional recommendations, I'm a very, very strong proponent of having a dietetics friend in your pocket. I love referring patients to dietetics whenever I feel like part of what they might be dealing with has a nutritional component. I myself had a running related injury I dealt with for just shy of a year. And after 6 months of that program where I was just hitting roadblock after roadblock, even though I felt like I was doing everything from a rehab perspective right, nutritional changes were what gave me a huge jump start and essentially saw results in weeks worth of time when I had struggled for months. So I feel like I have learned firsthand that although we can do everything right from a rehab perspective, if we're not giving our bodies the building blocks that it needs to kind of capitalize on that rehab program, we're not going to see results. Then on race day, we want to maximize our pre-race glycogen stores, and then we want to be consuming our carbs, fluids, and sodiums. There is some evidence for caffeine as a supplement. It has been shown as performance that it can be effective. Again, I defer to my dietetics experts to dose and tell people what the best sources to get those are. But just to know, caffeine does have some evidence behind it. And then I do think we need to address just how complex the nutritional puzzle really is. There are so many things, kind of like when we're talking about that injury threshold curve. With nutrition, it's a factor of our performance, right? Our casual runner and our professional runner running at a 4.5-minute mile pace are going to be very different. Our environmental conditions are going to change our nutrition. When it's really hot, when it's freezing cold, we're going to need different things. We're going to base our choices based on our specific body tolerances and how our GI systems digest different foods. And then this is a conversation I had with a patient a couple years ago that really factored into it for me as well. Thinking about aid stations, I was working with someone who was a professional marathoner, and she said when she switched over from being a recreational runner to a professional, all of her nutrition then was stored for her. They would keep it at the different mile markers that she wanted it. So she said she was then able to actually change her entire nutritional strategy because she didn't have to worry about carrying it. So thinking about whether someone is carrying nutrition, whether there are a lot of aid stations available, if we're talking about like our Ironman triathletes, whether someone is actually tracking them and bringing them their food, all of that is going to factor into the overall program. How much, I think, is always a good question to try and answer. And this calculation can be really helpful for that. So the caloric cost of running has been calculated to be 1.6 kilocalories per kilogram per mile. So just transitioning that to, pounds and miles. If you were a 150-pound runner running for 5 miles, that caloric cost would be 544 kilocalories. So in thinking about the overall needs and what the goals are of the program, that calculation might be beneficial. We know that in running, the low body weight, low percent body fat has the benefits of assisting fast, efficient running, and that it helps to facilitate heat dissipation. However, there is that two-sided coin again of chronic energy deficiency. So if we are running in that deficit for a prolonged period of time, there are consequences on reproductive function, on bone strength and quality, on cardiovascular health, and also on performance. And these we actually do cover in a lot more detail in the Red S section in our Women and Exercise course. If anyone has treated more than a runner or two, you've probably been asked about shoes. Shoes being the only real equipment a runner has to have, asterisk, right? Has to, do you even have to have shoes? This is something that they're probably going to look for your input on. So this slide is just talking about the anatomy of shoes. You know, we've got our uppers on here, our heel counter through the back, the outsole and the midsole being through here. Just all the different characteristics that we can talk about when trying to decide on an optimal running shoe. So the real question is not, is there one best shoe, but how do we select the right one? How do we guide people to the right option for them? So the historic shoe shop theory, as we call it, you know, when you go into a shoe store and they try and help you select the right thing, there was this, it still exists today. There is this program where they compare how your foot structure looks and the amount of support in the shoe. So under that program, high arched with rigid feet and people who have reduced pronation would be cushioned. People who have more neutral anatomy get put in something called the stability shoe. And people who excessively pronate or have lower alignment issues would be put in something called a motion control shoe. So when they do that, and most of these studies actually come from the military because the military can dictate what people wear, they matched people's morphology to that shoe type. And what they found is that there's really no evidence that if we prophylactically match those two, that we're going to reduce someone's injury risk. So really, we haven't seen that we can just match someone's footprint to their shoe type and make them less likely to get hurt. So what about cushion? Is cushion a more is more situation? With this one, the research says maybe. It's not really sure, though, who should have a cushion shoe. What I found to be really kind of counterintuitive is they found that when they compared people who had higher impact forces versus lighter impact runners, the cushion shoe actually were more beneficial for the lighter runners, which would have been the opposite of what I would have expected. But at this point, there's really no consensus on how much cushion is the optimal amount. What about the heel to toe drop? So when we're talking about drop in describing a running shoe, we're talking about the distance between the height of the forefoot and the height of the heel. So I think in an extreme situation, we're talking about the stiletto, right? So if we've got a high heel shoe, this would be a 4-inch heel would be considered like a 4-inch drop. So in a running shoe, not a high heel stiletto situation, typically measured in millimeters. So the higher end of drop is probably going to be around like a 12. That's like a standard high drop. And it can go all the way down to a 0 drop shoe. So they have looked into, is there an optimal amount? They found that low drop shoes may be protective against injury for the occasional runner. However, if you're a regular runner, this protective mechanism wasn't really there. So there isn't a universal recommendation on drop. I would say clinically, when I'm using drop, I'm typically talking about it with someone with an Achilles injury. If someone has chronic Achilles issues, I may consider having them preferentially look towards a higher drop in order to offload that foot by essentially having a heel wedge in there and offloading the Achilles. What about the age of shoes? So these are two of essentially the same shoe, one that's fairly worn out, one that's fairly fresh. Is there a difference in how much you're likely to get injured if your shoes are older? The research at this point doesn't really have an age of shoes that's the threshold for becoming a problem. They've looked at like the 4 to 6 month old category and saw that some men were actually at a decreased risk of having an injury when they were wearing shoes of that age, where some women had an increased risk. So there's really not a great consensus for age of shoes. My greatest feedback on that particular threshold is 4 to 6 months isn't really for your recreational runner, probably going to be the threshold where we have an excessive amount of wear like we see in these pictures. I'd be curious if maybe the data would look a little different if we were looking at shoes that were 12 months old or more. But really, it doesn't have at this point a classic threshold where we need to just be telling people at 6 months, replace your shoes and you'll be better. What about the cost of shoes? So expensive shoes should be better, right? And the question on that really hasn't been validated. They've actually shown that some of the cushion performance doesn't really have a correlation to cost, that a low or medium cost shoe may actually have as good of a subjective comfort as a more expensive model. So there's really no specific brand or cost where we know if we steer someone in that direction, we can get them better results. Kind of poses the question of like, should runners even be wearing shoes? Is this whole shoe question kind of a moot point? There was a big barefoot minimalist shoe, I would say movement maybe about 10 years ago. And they found that it could improve the running economy and it could build the cross-sectional area and stiffness of the Achilles. However, the flip side of that is it also increases the loading of the ankle. It also increases the loading of the metatarsal joint. So although there may be times where it's beneficial for someone if they have maybe a lot of tibial stress reactions or patellofemoral pain, they may want to go towards more of a minimalist shoe. However, there's really not a good foundation for us to globally recommend this across the board because it may also overload tissues that could also be vulnerable for stress fracture or tendinopathy. There's a big trend in the past maybe 3 or 4 years for maximal cushion shoes. The evidence doesn't really show that it changes the impact loading. There's not an innate biomechanical difference in how someone runs when they wear a maximalist shoe. So we don't know the effect on pain and injury. So at this point, it's kind of a maybe, it might help, but we don't necessarily have any evidence that it does. A similar evolving trend is female-specific shoes. So women have, different anatomical characteristics. They have different physiological characteristics. So there's a theory that if we make them shoes that are special for them, maybe we can kind of negate some of those problems that we see specifically in women. And when they compared men and women's shoes in this population, they actually saw that there was no difference in the mechanics of how they ran or the physiology of where they ran. So really not much need to steer someone towards a female-specific shoe. So the bottom line is really then what do we do? How do we tell someone what to pick? And of all the studies, the one that has the best evidence behind them is showing that a runner's perspective on the feeling of comfort is really more supported as an injury prevention tactic than anything else. So if your patient thinks their shoes feel right, they're probably the best resource we have to determine if that's the best shoe. We want any major transitions in shoe type to be done progressively because, of course, it could just load structures differently. And in general, we should be encouraging our patients to listen to their body when they're training. If they're thinking that there is an issue, we should really be kind of exploring what that might be. There could also be some evidence between alternating pairs of shoes at this point. So that could be something we, again, do more gradually. So then finally, our topic, just to wrap up, would be outcome tools for the runner. So if you're trying to identify, are your interventions successful? We oftentimes see the ceiling effect in higher level athletes or runners. If you're looking at like a lower extremity functional scale or using some of the other types of outcome tools, a lot of times there aren't a lot of questions related to high impact activity. So the University of Wisconsin, which shout out to my alma mater, that's where my undergraduate and my doctorate and my husband's both came from as well. So we're big UW fans. This is an outcome tool they actually created for that purpose. So the things that they talk about are not just pain, but also how do you feel with mileage? How is your distance and pace? What is your confidence in running? Some of the psychological components as well. So you can really capture a better picture of the overall recovery of the runner. So that brings us to our conclusion of today. So running is really a widely utilized activity. We know it's both in the US, but also really worldwide. So as runners often encounter frequent recurring injury, it's critical for us as their providers to consider the unique biopsychosocial needs of the population across their whole continuum of care. How do you know if you should continue through pain during a return to running program? This is a really great question because it comes up a lot in the return to running process. I think it's very uncommon actually to have a runner initiate this phase of their rehab program without having some degree of pain. So, being the one to help your patient interpret that pain is a really important role for us as therapists. So, the question comes down then to how do we know if we should encourage them to continue through or if we should scale back or hold off on the running program for a while? So there are a few different characteristics that we look for. First of it is the intensity of pain. So we have a very different tolerance for allowing our patients to push through pain when it is on the lesser end of the intensity scale. So usually if a patient is reporting pain in the 1, 2, or 3 out of 10 scale, that's something that I'm a little bit more tolerant of than if they start getting to 4 and above. So typically those lower ends of the pain scale. Now that will also matter based on what their baseline pain was. So if they were coming in with nagging 3 to 4 out of 10 pain, then truly at this point we'd be recreating their full symptoms. So that's not something I would be as willing to let them push through. However, if they were having more severe pain and then it's a milder version that they feel when they're doing their return to running program, then that may be something that they're a little bit more likely to still be successful if they push through. So intensity is that one piece of it. The other component comes to the duration. So is it just achy or sore when they're running and then after the run does it feel okay or feel better? Or are they having this pain while they're running and then going home at the end of the run, still having some lingering pain for the rest of the day? Are they feeling it at night or the following day? That again is pain that I am not as willing to let someone work through if it is persisting past the actual activity. So intensity and duration being some of that. The other component would also be the quality. So if we're having something that we've alluded to already in this answer that's dull or achy, that is something that I find a lot less threatening in their rehab program than if they're having something that's sharp or stabbing. So, in general, if we can have a lower grade, maybe a 1 or 2 that's dull and achy, and as soon as they're done running, it pretty much subsides, I'm typically allowing them to continue through some of that pain. If there is more of a 5 or 6 that's sharp or stabby, that's continuing into the night or rest of the day after their run, then that's something that's telling us that that tissue isn't quite ready for that progression into running. And then at that point, it might just be something where we have them take a little bit more rest in between, or we might have them do a little bit of strengthening before going back. There is also a difference in tolerance based on their diagnoses. I would likely have a higher tolerance for people pushing through a little bit of soreness if we're dealing with a diagnosis like tendinopathy compared to something like a bone stress injury, where rest was really our primary treatment and trying to prevent them from having a higher level complication. So, again, a little bit of intensity, a little bit of duration, some of the quality, and then also that underlying diagnosis and how that interplays into the answer. What are some good exercises preventatively for sprinters, specifically for hamstrings? So this question sounds to me like it comes from someone who has treated sprinters in their career, because their most common injury truly seems to be hamstring injuries. And not only do they happen a lot of the time, they often recur. So once someone has a hamstring injury, we see them unfortunately tend to come back. So being preventative for sprinters is huge. And as we talk through some of these exercises, it is great to point out that our sprinters and our endurance runners do have different injuries, but they also then have different rehab and preventative. So we talked about in the course today how the injury profile differs for sprinters and for endurance athletes. And there are some different things that we can do for those shorter distance, high intensity runners to help safeguard those hamstrings a little bit. And what we see is that those exercises are the eccentric exercises. So the ones that are under high load and that eccentric lengthening phase. So with our sprinting population, we see that the hamstrings are under a significant amount of stress when the knee is coming into extension before we get heel strike for each of the strides. So trying to give that hamstring a little bit of a boost during that eccentric lengthening phase, especially at the end, can be really helpful. So to make that practical, so I answered conceptually to start with. Preventative exercises for sprinters, specifically in the hamstrings, would be eccentric exercise. But specifically within that, some that I really love, there is great research backing behind the Nordic hamstring curl. So that's the one where your sprinter is up and tall, kneeling, and then their ankles are stabilized, so often by another person pressing down on their ankles, and then different arm positions, but just for our example, we'll put hands across the chest and then keeping the trunk completely stationary. They are lowering towards the ground, bending at the knees. So those Nordic hamstrings have been shown to be one of the exercises that has great return in terms of hamstring protection in sprinters. If you're looking for fostering a more comprehensive program where not you're just focusing on one exercise, some other eccentric hamstring ones that I personally like involve windmill lunges. So that lunge exercise is really functional for runners because of the split stance and because of the range of motion that we're getting through with that. And then when you add the windmill, so meaning that one arm is up and then you're reaching down and tapping the opposite foot with your hand when you're in that position, that allows for extra eccentric control of lowering through the trunk. So the windmill walking lunges are a really great one for sprinters as well. I also love RDLs. So your Romanian deadlifts, your single leg deadlift position, those are allowing you to often add resistance, so adding weight to that forward eccentric at the hip, because the Nordics are getting our eccentric motion at the knee component of the hamstring, and then those RDLs are going to make it comprehensive and be up at the top for the hamstrings as well. So we've got the full body with the rotation of the windmill, and then from the top and the bottom with those other two. There are more great ones. You can do bridge Swiss ball rollouts. So if you're on your back, have your feet up on an exercise ball and bridge up, and then roll the ball out, lowering your hips back down on the way back in. So lift, roll out, lower, and back down. That can be done both double leg or single leg for an even harder version. Rollouts can be really helpful for sprinters who are trying to eccentrically train their hamstrings. If a patient doesn't have, or in this point, it might not be a patient yet, if this runner doesn't have an exercise ball, you can even do that on the floor with a slide out using either a magazine or a dish towel on a slippery floor, and just coming up and bridge, foot on the ground under a slider, slide out and come back down. Those are all great eccentric loads for the hamstrings, which can be great for prevention of injuries in our sprinting population. Is it recommended to use hill training when recovering from an injury? Hill training during rehab recovery is very much an it depends answer. So hills, when we're running up them and down them, offer a difference in loading than we do when we run on flat ground. So when we're running uphill, we have to think about the mechanics of how they're going to change when we're running up the incline. So you're going to have increased dorsiflexion through the ankle in order to achieve that toe up to run up the hill. You're also likely going to have more knee flexion when you're running uphill as well, because that stride is going to be reaching up and the ground is going to be hitting it sooner. So you tend to have more dorsiflexion, more knee flexion, and slightly more increased trunk lean when you're running on an incline. And the reverse, when you're running downhill, you're likely going to see more of that eccentric dorsiflexion, so the control of the lowering of the foot. You're also tending to see more full extension of the knee and that longer stride as someone goes down a hill. They might actually be more likely to lean backwards as they're running down the hill. So the mechanics are going to be significantly different. In general, running downhill, although exertionally for the athlete, it often feels like less work. From a musculotendinous perspective, we're often seeing increased workloads on the tendons as they're running downhill because of the fact that they are then having to control the gravity and the eccentric lowering phases of all of the joints from the knees to the ankles. So when we're talking about being in a rehab program and trying to recover from an injury and using hills, typically running downhill is going to actually put more stress on knee control and the anterior shin. So someone who has shin splints, someone who has a stress fracture in the shin, someone who has knee pain or IT band issues, or someone who has glute tendinopathy or some kind of hip issue, I would find declines on hills to be an increased risk for these people. When we're running uphill, sometimes we can use them to decrease some of those mechanical loads. So if you have someone with a hamstring injury, they might actually have less loading when they're running up a hill. Someone who is returning post stress fracture, they may also have less issue when they're running up a hill. But typically, it's something that we integrate after they've established a baseline on level surface. So oftentimes I'll have someone work through their interval program when they get up to a steady state. Then I'll introduce hill training as a return more to their normal training routine, similarly to how I would add speed training. Hill training, speed training, once they've established tolerance for running in general. However, there are some exceptions to that. If you are trying to find ways to offload certain mechanics, you want someone to try and reduce their overstriding. You might have them run up the hill during their recovery. So might be people who were in patellofemoral pain types of problems, or again, maybe your lower leg injury and stress fracture or shin splint type of patient. So there are roles and times where hill training might get used during this recovery. However, it's often saved till later on if someone is tolerating your baseline running program fairly well. How do you change the treatment program for a runner in training for a specific event? With this question, I think it's a really valid point to discuss because of the way that as athletic and sports and ortho providers, we really need to take into context what our patient's role is at the time they work with us. So if somebody is maybe in their off season and has just finished a race, their next competition is far out into the season, and we have some time, we might really focus on trying to get someone down to their baseline, try and really remedy the symptoms, really look at the sources of how we got to this point, and gradually build back up in order to create a system that's more resilient and maybe even better off than it was in the previous training cycle. However, if the same person with the same problem is coming to me, let's maybe start at a month out from a race. So at 1 month out to the race, they're still going to be most of the time in a building part of their training program where they're still adding on miles, trying to work up towards their race distance. So if I'm working on the training program at that point, trying to meld it with my rehab program, what I'm going to need to do is try and find ways to balance relative rest and offloading of an angry tendon while still allowing them to accumulate mileage. So it might be increasing rest periods between runs. Maybe it's offloading if they have access to something like a reduced gravity treadmill, water running, things where we can still keep up with that goal of building while also satisfying a rehab goal of trying to create relative rest. Now, if somebody comes in and they are 2 weeks out from the race, then they might be in more of a taper phase where they might actually be pulling back and resting things to try and allow them to be in optimal state for race day. If someone comes to me during a taper phase with an injury, I'm much more likely just to suggest to them that they cross train instead of running at all. At that point, they've already created their necessary base for race day and proven that their body can get to the mileage that they need. So because the natural training program at that point was to scale back and have relative rest, I'm going to transition that relative rest then to being, instead of low mileage, to cross training. So again, that's the mending the gap between our rehab goals and our training goals. Now, if someone comes to me on race week and which actually happens quite a bit, where people are pushing through, and then panicking the week of the race that, okay, I only have 2 days, I only have 3 days before my race, and I'm now concerned I'm not going to be able to line up. What does our rehab look like at that point? And for me, it is much more of a goal of symptom management, pain reduction, and attempting to get them the greatest tolerance for activity as possible in that time. So if someone is coming in and has, let's just say, an IT band that's really flared up, we might use strategies like dry needling or instrument-assisted soft tissue work. We might be working on taping or mobility through the knee joint or through the hip. Talking about maybe some temporary gait modifications that they might be able to make in order to offload the knee during their impact phases, all things that are going to have a short-term impact. And then later, after the race, we can come back and look at how they got there and really work on more of those ground root causes. So again, depending on what their training phase is, I try and match the rehab phase to match that. What are some potential causes of headache during or after running? Headaches can be generated by a few different things when we're running. I've actually dealt with these myself as well and have played around with the different causes to try and find what they can be and how to solve them. At baseline, nutritionally, we always need to start and think about that. Could there be a hydration concern or a nutritional concern from a caloric deficit? Now, of course, as far as we need to discuss from a thorough perspective, headaches can mean a lot of different things. We want to make sure that these are really exertional and exercise based headaches and that this isn't a sign, of course, of something bigger or more serious. So we need to be doing a red flag screen to make sure that these headaches aren't signs of a bigger, more referral worthy issue. But if we determine that they are more appropriate for a conservative intervention, then that's when we can go down this path of trying to identify the cause. So hydration and nutrition, top two easiest to check off the box if we know that we've got those under control. We also can actually consider environmental factors. So if a patient has either sensitivity from an allergen in the environment, we can look for differences between running indoors and running outdoors. Sometimes that'll tell us whether someone is actually having a seasonal type of allergy reaction while they're running, and that can give headaches. Environmentally can also be related to sun. So some people will have sensitivity to the amount of sun that beats down on runners when they're outside. So if there's a difference between the type of day that it is, and again, indoor versus outdoor, you might have a suggestion for headaches like running in sunglasses or using baseball hats to shield the eyes during running. Those can both be helpful options. There are also potential for muscular trigger point type referrals as well. So there are some times where runners will have a really tight and locked up upper trap and scapular region when they're running. And if that's the case, people may get tension headaches actually from their scapular muscles while running as well. So working through some mechanical things with that or working out the soft tissue afterwards can also be helpful. And then one that I just want to mention that I've actually seen in my own clinic, but is not definitely as common. I've only really seen it one time in someone who didn't have a concussion, but are the vestibular ocular components of it. And again, treadmill versus outside can be helpful to identify that, where if the environment is having a difficult time processing with the vestibular ocular system, we can get some vestibular type headaches from the environment running past them on a run as well. So headaches can sometimes be nutritional, they can sometimes be environmental, they can be musculoskeletal or trigger point related, and also they can be vestibular ocular. So lots of different causes, they have slightly different presentations, so that can be used to identify which is which.